And it's doing its little bar of making, oh, so I don't think you guys, Denise, if you did go to the YouTube channel, make sure you mute that right now.
You can't find it now.
Okay. Doing its little bar, and I have to. Oh, so I don't think you guys, Denise, if you did go to. I'm now muted. Okay.
Maybe they can hear it.
Let me see here. Hi there, Science Colloquium audience. If you are already here, we will be starting our presentation at 3:15. So welcome to Science Colloquium. I'm glad you're here. Today we're going to talk about nursing in Zambia, and we're going to wait right till 3:15 and then we will get started. So just be patient and we'll be right with you. Yeah, so we have about 4 people now. So it'll go at after just a couple minutes. Hey, I just would like to welcome people to Science Colloquium. We're going to be starting in just a minute. If you have any questions, please leave them in the chat and we will read them at the end of the talk. And we're glad you're here today. And Denise, I'm going to hand it over to you.
Hi, I'm Denise Barjesteh, and I'm on the Science Colloquium Committee. And before I introduce you to today's speaker, I want to tell you about the upcoming talk on Science Colloquium. The next one, 2 weeks from now, is by Annie Foster, who is the COO of a Nexus Biogas. And the topic is called California Cow Power 2021. And we will be talking about the Santa Claus County dairy digesters and the method of replacing diesel and reducing the carbon footprint of dairy and transportation industry. So that could be an important topic dealing with how we can help with climate change here in our county. I also want to let you know about the last speaker on December 2nd has been changed. It was going to be an astronomy topic on the sun, but long story, but we had to change the speaker and the topic. And so it is now being done by Steve Nell, who is the general manager of the Oakdale Irrigation District. And he'll be talking about the Tide Dam project and the Honolulu bar restoration on the Santa Claus River. So that could be another local interesting talk. So now, let me introduce you to Tania Barjesteh. And I had the pleasure of knowing her when she was a student at MJC, and I was working there as the anatomy physiology lab technician. And it's been a privilege to watch her get into the nursing program and go through the whole program. So I'm excited to have her here today. And she was born and raised in Turlock. She initially went to school to become a veterinarian technician, which she did for about 8 years before she started studying to become a nurse. She graduated from the MJC RN program in April of 2016 and started working that fall at Doctor's Medical Center, where she still is. She started out at cardiac telemetry and then switched to the surgical cardiovascular ICU in January of this year. And she also got her bachelor's in science and nursing in 2018. So Tania, I'm going to turn it over to you now.
Hi, everyone. Thanks for having me. I appreciate the opportunity to tell you about the experience that I had. I was asked to talk a little bit about myself before we kind of jumped into it. So Denise kind of covered the basics. Nursing was not my initial go-to. It took me a few years to figure out what it was that I really wanted to do. So I work as a vet tech for about 8 years. Initially, I got into that thinking I was going to be a veterinarian, and I kind of changed my mind. I was trying to take the time to figure out what I wanted to do. So my path was anything but linear. So if you're kind of going about figuring out what you want to do in a roundabout way, you'll get there too, I promise. So I started working at Doctor's Medical Center in Modesto in the fall of 2016 on a cardiac telemetry floor. And then I worked there for about 3.5 years before I switched over to the surgical and cardiovascular ICUs in January, which is where I work now, and I love it. So I had the privilege of being able to go to Zambia, which is a country in Africa, last March, and it was probably one of the best experiences of my life. And so I kind of had talked to Denise about it, and so she asked me to speak. So I guess we'll jump right in here. So I kind of covered that stuff. So this is just a visual to give you an idea of where Zambia is. It's kind of in the southeastern part of Africa. We flew in to Lusaka, which is the capital, and that's where we did most of our work, in or around Lusaka. So the total population is about 17 million people. Lusaka itself has about 1.7 million. Like many third world countries, they have poor healthcare resources, mainly a deficiency in providers and clinicians. So, which is why trips like the one we took were so valuable. It's just, getting people out there who know how to treat people or educate them on healthcare and things like that. Let's see. So a little about the WHO strategic plan. Organizations like the World Health Organization try to come up with sort of benchmarks and plans for countries like this in terms of healthcare, setting goals and trying to provide support and stuff like that. But as of right now, there is such a deficiency in healthcare providers, whether that be doctors, nurses, other types of clinicians, that they just are so few and far between. People don't have access. And a lot of the region is still very rural. Like Lusaka itself is pretty metropolitan, but you drive just a little ways out and most of it is rural, which is the majority of the population lives out in those types of areas. So it's hard to get to professionals that can provide healthcare services. So the reason I decided to go is because doing a mission trip of some sort is something that I've always wanted to do, specifically to Africa. I don't really know why. It's just always one of those things that was like kind of in my heart, like that seems to be a place that has a lot of need. So I was talking to a fellow nurse and she kind of had the same idea. She really wanted to do something like this. So we just, we did a little homework and we decided to go for it. And it was something that was, like I said, one of the most rewarding experiences. So if there's something like that, something of service that you want to do, I say just go for it because it is so rewarding. And you really make an impact on these people's lives. So this is just a quick picture of me and the other nurse. There is a nurse that I used to work with that we went on this trip together. We also had the privilege of working with some of these kids are dental students, for like not dentistry the way we think of it, but they're dental clinicians. And they were studying to do that sort of thing. So they came and helped us. We provided both medical and dental services. And they also acted as our translators. So we got to know these guys pretty well. A lot of people actually spoke English, but for those that didn't, these guys were invaluable. And this super cute baby, I just wanted to throw in there, like, why wouldn't you want to go and, help people like this? Look at these kids. Amazing. The people were amazing. Aside from the healthcare stuff and all that, just meeting these people and talking to them and hearing their stories and getting to know how they live and stuff like that, it was very eye-opening. And they were so gracious and thankful. So a little bit about the team. I traveled there with a group called International Medical Relief, or IMR. They're a nonprofit organization that was founded in 2002. They primarily, their goal is to sort of reach out and help countries that have been excluded from our global healthcare system, that is deficient in resources, and access to healthcare. And they also provide a lot of education, which was a big role that we played, is educating people just like on basic healthcare maintenance type stuff. Like I said, we provided both medical and dental services. We had 9 providers, and that included doctors and nurse practitioners, and I think we had a physician assistant with us too. But it was primarily doctors and nurse practitioners. There were 9 of us nurses from all different backgrounds. We also had a lot of non-medical staff with us, but like, you know, some of the providers or nurses or whatever brought their families to help, and they were awesome too, helping set stuff up. We actually put some of them work in our little makeshift pharmacy that we had in our bus. And they really were amazing. So even if you're not medical or you know, not in a profession where you think something like this would be possible, you could still participate and provide a great service and have that experience. We also had a dentist and a couple of dental hygienists, and as well as the dental technician students from Lusaka itself. This was most of the team. I don't think our dental people are in here, but this is the majority of us. This was on our last day or second to last day there, I think. And these people were also amazing. You would think that there would be some sort of conflict with a bunch of medical professionals from all over the United States, but really generous, really great teamwork, amazing people that I'm still in contact with, a handful of them as well. You make some pretty cool friends and lasting friendships on these types of things as well. So a little bit about what we did and where we went. Like I said, we were primarily just outside of Lusaka itself. And most of our clinics that we put on were in rural areas. So we basically went out into a field, set up some tables, or found like a broken down building that wasn't really used for anything, just for some shade, and we would set up some chairs for the providers, and we'd just kind of like, you know, funnel people through. So we went to a refugee camp early on. We set up multiple rural clinics. We went to a couple of shelters. And then our last big clinic, we actually went to the main prison in Lusaka and treated both the women and men's sides there. And I'll kind of go into more detail as I go on here. So this was actually our first day. We went to a refugee camp. The refugees were from kind of all over neighboring countries. A lot of them were from the Congo. And this is a good representation of kind of where the types of places we would set up. There would be like a cement building that was empty on the inside, and we would set stuff up and, you know, kind of funnel people through as best we could. These were our exam rooms for the providers, set up outside of that building. So there would be 1 or 2 providers in each one. And if the person that we kind of triaged needed to actually see a doctor about whatever it was that they had going on, we would send them to whoever was available. That's the inside of it. It's just kind of a dirt floor with canvas over top. This was the rest of the refugee camp, or just kind of a slice of it there. These were the little living areas. This was a shelter that we went to, and I kind of use this term shelter loosely. This was for kids specifically who either didn't really have anywhere to go, or needed somewhere to go at least part of the day, they could get a meal here. They could get, medical services as best they could provide. They would get maybe a little bit of sort of general education, but nothing major. Definitely, I wouldn't call it a school. These are some of the kids we got to see and meet. This was a school that we went to that was set up by a mission or something, I believe it was. I don't remember exactly, but it's called the School of Hope, and you can actually find them on Facebook or online at the Village of Hope or the School of Hope Zambia or something along those lines. I have a link later on if you're interested in learning more about them. This is a school, a formal school from K through 12, I believe, that's set up outside of Lusaka for either homeless kids, or it's actually linked to an orphanage as well. So they have an orphanage on premises. They are able to educate the kids. Our dental team spent a lot of time here doing cleanings and, well, for both students and teachers. That's kind of the main courtyard of the school there. This was another one of our rural clinics. This awesome lady is a nurse in Zambia. And the way it works is the nurses there get maybe 6 to 8 months of training from scratch to 6 to 8 months. And then you are in charge of a region, not, 2 or 3 patients or 4 patients or whatever. But you get a region, a territory that you're in charge of, and you go and do your thing. And so it was really cool to talk to this lady about kind of what she did and how she managed her territory and her patients. So she was kind of our guide in this area. This was, like I said, literally a kind of a mowed down field. You can see the path that was mowed down there, and just a sea of people waiting for us to be seen. Again, just kind of in these little makeshift buildings that they set up or had set up for something else that weren't being used anymore. This was one of our other clinic locations. This was a really cool experience for me because this was one of the latter clinics as well, and these young people in white are actually nursing students. So we got to spend some time with them, and that was extra special for me because I also really like teaching. So, we taught them how to take a blood pressure and, ask questions to get medical history and what to listen for and how to do things, just basic assessment skills. And they were really cool. These 3 spent the majority of their time with me. So that was a really cool experience. More of the folks here waiting to be seen. This little girl was a very interesting case that we saw. I think a couple of our providers saw 2 or 3 of these and all the people that we saw, but it's fairly common in that region. She has what's called river blindness. It's caused by a parasite that's carried by a certain type of fly and mosquitoes and stuff like that. So it slowly causes these people to go blind. So this was, we had a couple of really interesting things that you don't really see that often here in the States. This was one of them. So overall, over the 5 or 6 days, 5 days that we that were actual clinic days, we saw over 2,000 people. In the prison alone, we saw over 1,000 on the men's side, and on the female side, we saw there were about 170 women. 4 of which were pregnant, and then the children up until, I think, up until they're 2 years old, they stayed with their moms. And then if the mom was not released from prison at that point, they were sent to an orphanage or something along those lines. And the prison, when I say prison, it's not like we think of prison here. Prison there is, you were arrested for one reason or another. It could be for something super minor to super serious. And that's basically where they hold you, whether or not you're convicted officially. It could take months, it could take years, depending on the situation, but they just kind of put them in there to hold on to them, and then, figure it out from there. So it's not quite the same way we think of prison. So we got to treat these people as well. Very gracious, again, very nice people to talk to. Most of them, the majority of them, were fairly minor offenses. A lot of it had to do with immigration stuff and things like that. So some of the more specific stuff we went over with these people, like I said, a lot of it was education, just basic education about maintaining health. Like, unfortunately, a lot of these people had access to clean water, so that wasn't a big issue in the area that we were. But just as simple as you need to drink water throughout the day, especially if you're outside, We also provided them with kind of a basic medical history document so that we could document things for them for their visit with us. And then they could keep that with them the next time they were able to see some sort of a provider. They could say, especially if it's related to what they were seeing with us, they could say this is what they did, and they actually had a medical record, which is very rare in areas like that. We're spoiled. We go to the doctor and they type a couple keys on the computer and pulls up our whole medical history. They don't have that, and a lot of them aren't educated enough in like basic healthcare to be able to communicate what they were seen for previously. So documentation was a big thing. Just the opportunity to see a medical provider was huge for them, to give them access in rural areas. And we did have, like I said, a makeshift pharmacy for basic medications that, IMR has a lot of experience in these regions, so they know what types of things are commonly seen. So they, pack appropriately as far as their medications and treatments go. So we were actually able to prescribe meds. We did, antibiotic injections or pills or whatever the case may have been. So we were actually able to provide some treatment. There were a couple people that I think we had an appendicitis case that we had to make sure that we were able to, sort of ship him out and get him to a hospital where he could get the care he needed. So there were a couple random cases like that, but for the most part, we were able to treat the patients that we saw. And education was huge. Just sitting down and talking to these people about basic, maintenance and how to take care of yourself and the things to do to keep yourself healthy, prevention type things was huge. And that was how we spent the majority of our time. As far as the nursing staff, that's how we spent the majority of our time, was educating people. Like I said, the access to providers and clinicians was super limited. One sort of family that we encountered was, I think the woman had some sort of a skin condition. It wasn't anything super serious, but they had ridden to our clinic. I think it took them about an hour in their ox-drawn cart. It took them about an hour to get to us. And then they were seen, she needed some type of, I think she needed steroids or something like that. but we just had a limited supply. You know, she needed it for a long-term treatment to get rid of whatever condition she had. But it was a 5-hour bus ride to the nearest pharmacy for them. So, which they weren't able to afford either. So we were also able to provide them, you know, a limited supply so she could start her medications. Our team leader, that was an IMR representative, gave the husband money for the bus ride, money for the pharmacy, for the meds from the pharmacy, and a prescription from our provider. So it was a really cool thing to be able to do for this family, something that we take for granted. You know, how many pharmacies do you drive by on your way from, you know, home to work and back again? There's one on almost every corner, but for this family, it was a big deal. You know, a 5-hour bus ride one way, so that's your whole day just going to the pharmacy. So we were able to help in some small way to be able to get them access to the things that they needed. There's a lot of those types of barriers for people in these regions, just getting to where they need to be. The majority of essential medications are not adequately available in Zambia. So this is what essential medications are, from a list that the World Health Organization has, you know, labeled essential medications. So even like basic stuff, they have a hard time getting. So the fact that we basically had a pharmacy on wheels was a big deal too. So we could get the medications to them as opposed to them having to try to get to the medications or having them available. So experiencing this in a country with very limited resources kind of got me thinking about healthcare disparity, not just globally, but locally. We have a lot of disparity in our country as well. We're very fortunate that we have access. Mostly we have access to healthcare and sort of the basic necessities for that type of thing. But, you know, there are a lot of people here that are in need as well that, you know, as a healthcare employee, we need to be aware of that sort of thing and try to do what we can to serve the vulnerable members of our communities as well. So just thinking about, you know, this is kind of a point of comparison just to see, I think it was like a 15-hour flight and then another 3 hours. So we flew in to Ethiopia and then another 3 hours down to Zambia. So 18 hours away. And we have a lot of parallels as far as healthcare disparity and taking care of our vulnerable communities, especially at a time like this, where when something like a global pandemic hits, you know, those vulnerable individuals are the ones that often take the brunt of it. So, you know, it's important to consider that sort of thing as a community and trying to take care of those that are maybe not as fortunate as some of us are. And education is a big deal, even just here. I did a presentation during my BSN program. I did a presentation for the nursing staff in the MJC Health Center. I got a chance to talk to them a little bit about some of the statistics in our county. And there's a lot of deficiency in healthcare education just locally, you know. I think especially when it comes to things like sex education, you know, a lot of teenagers don't know that, you know, you have a baby from having sex, you know, like that basic. So, you know, education is huge, not just abroad, but even locally. So, in terms of taking the onus for someone who maybe isn't going into healthcare, doesn't have a healthcare provider in their family or anything like that, making sure that you're educated about how to take care of yourself and your loved ones, and making sure you're trusting credible sources, because there's all kinds of misinformation. I mean, you guys saw it with when COVID hit, all the misinformation there was just at the beginning of that. So even just basic information, basic healthcare maintenance, educating yourself from reliable sources. You know, you have the CDC, you have the World Health Organization, you have doctors and nurses and other medical providers in your community that this is what we do for a living, you know. I would probably trust those people over, you know, anything else. So education is big when it comes to providing good health care, whether it's here or in another country. So if you're interested, here are some ways that you can help. IMR's website is just internationalmedicalrelief.org. And they are a nonprofit organization. So if you just want to donate, if you're not able to go on these types of trips, you know, the donations are tax deductible, all that kind of stuff. So that's a win-win, right? And if you did have at some point in the back of your mind, I know this year's been a little bit tricky in terms of travel, but they are an amazing organization. I gotten to see what they do firsthand on the ground, and they do make a big difference in our global community in terms of providing healthcare services. They are not a religious organization, if that's something that matters to you. So, and there are lots of religious organizations that do things like this. So if that's something you're interested in, seek those out and just go for it. It makes a huge difference to them. It will make a big impact on you, I guarantee that. This is the second link here is for the Village of Hope, that school that I told you about that's linked to the orphanage. They also have a Facebook if you want to look at them, you know, look into them anymore to help. And there's so many other organizations that provide services like this across the globe. Especially now when something like this hits, people tend to sort of isolate, not just physically, but when it comes to reaching out to help in other ways as well. So, you know, assistance and volunteers and things like that are in short supply right now, I'm sure. So even if, you know, make a donation or whatever, these organizations do really good work, and I guarantee they haven't stopped doing what they do. So there's some references. Again, the Center for Disease Control and New England Journal of Medicine, things like that are good resources as opposed to just something somebody wrote on Facebook. So that's pretty much all I have. Thank you for having me talk, and I hope it was enjoyable and educational in some way. Yeah, that's it.
Hi. Can you guys hear me? We have a few questions. So
Okay.
let's see. One person, hi, would you upload this live in your channel so we can watch it anytime? And that one's for me. And yes, this will be available on the MJC Science Colloquium channel. So you can watch this anytime you'd like to in the future and share it with others, please. And okay, so here's some questions for you, Tania. Were you able to treat the river blindness?
So there were a couple cases that were not super far gone that we were able to at least give them medications to get rid of the parasitic infection. But as far as I know, and I could be wrong, I don't know the extent of the actual damage, but I'm pretty sure it's permanent. I don't think it's reversible. And there aren't a lot of like ophthalmological resources out there. We didn't have any that type of thing with us. So, we gave the medication, the antiparasitic medication for the infection, but as far as the blindness, I don't believe that is reversible.
Okay. Yeah, thank you. And then one student was asking, who do you contact to provide these volunteer services or maybe get involved with these services?
Yeah, so like I said, IMR is a great organization, and you don't, one of the things that is really cool about them, as opposed to going for months at a time, you can do a week-long stint and still be able to participate in this type of stuff. And they go all over the world. There are several in South America. There's a bunch in Asia and Africa and all kinds of places that are in need. So you could go anywhere, for a week. I think they have even a few that are like 4 days long if you don't have a lot of time to donate, but you still want to participate. And I know I'm plugging them a lot. They're the organization that I have the most experience with. So, but they do really good work. So IMR, or internationalmedicalrelief.org. You can check out their website. They have all their different trips listed. I haven't looked recently, so I don't know if there's some limitations with COVID and stuff like that. So you'll have to kind of research that a little more, but yeah, honestly, it's a quick Google search. If you look up, mission trips or medical mission trips, if you're interested in having some exposure to the medical stuff. And with IMR specifically, you don't have to have any kind of medical background. If you still want to go with them, they'll take you and they'll put you to work doing something else, but you can still participate. So
yeah, that sounds like a great experience for anybody, just to get out and see something and help out. I think that's pretty great. I will put the link to IMR in the notes for the video. So if somebody wants to come back and check that out later, but you can Google that also. And then were there any cultural differences that you came across, and how did you adjust to those?
We didn't really run into anything specific. I know another nurse that I actually went to school with was in Africa the same time that I was there. I don't remember which country she had gone to, but I know that they kind of briefed her, whoever she went with had briefed her on some of the cultural taboos and things like that, but she was actually at a hospital. With us, I don't know if it was because we were just in a rural area, but we didn't really run into anything like that. They certainly had learning about kind of how they manage things versus how we manage things. Like we were talking to one of the sort of regional nurses at one of the clinics, and she was saying that when a woman is pregnant and she goes to deliver her baby, there is a facility that they can go to. It's not really a hospital, but there's a nurse or a midwife there to help them along. The family all goes, they pack everything up and go. They have to provide all their own stuff, all their own food for however long they're going to stay. And they're kind of left to their own devices unless something is wrong. So different things like that as far as medically were really interesting to learn about as far as how they do it culturally. But we didn't run into anything that would be like a taboo or anything like that in terms of us interacting with the patients. And on that note, we actually did have an OB with us who had like a little portable ultrasound machine. So we were able to, a couple of the women got to hear their baby's heartbeats for the first time, and they were like 8 months pregnant. So that was pretty cool.
That's great. That's really cool. I think we have one more question. Oh, okay, yeah, one more. What kind of sexual education is offered in Zambia?
None to my knowledge. I don't, not everybody goes through school. Like, a lot of kids here get sex ed in school, junior high or high school or whatever the case may be, right? Not everybody gets that over there. So for them, it's kind of like, life experience, I guess.
Yeah.
So we were able to talk a lot about that. And, HIV is a big deal in Africa and all the countries in Africa. So that is actually something that they're somewhat educated in, because it affects them regionally so much. So when we were talking to some of these patients in terms of what their medical history was, malaria was a big one, and HIV was a big one. So, they knew that they had it. They knew that they were on their antiretrovirals that they had access to. So in terms of that type of stuff, but as far as, when we went to that shelter with the kids, they kind of split us up. So the female staff were with the girls just to, so it wasn't awkward for them. And we did talk about, kind of hygiene stuff when you're, on your menstrual cycle, or, preventing pregnancy or STDs or things like that. So it was very much at the basic level, just giving them some exposure to that, I guess. A lot of them were just like either had no clue or were too embarrassed to talk about it. So, it's very, very limited, the education that they have in terms of anything medical, and that includes sex education.
Well, that's really interesting to hear that. Lots of thank yous on the chat. So thank you so much for giving this talk today and sharing your experiences with us. We really appreciate it. I want to remind people that we're back in 2 weeks, November 18th, to talk about California cow power. And that's it for our program today. Thank you so much, Tania.
Thank you for having me. It was a pleasure.
Thanks. All right. And I'm going to close off the Zoom. Thank you. Bye-bye.
Thanks. Bye-bye.